dose of medication a day. But they're in range of initial and ongoing side effects, which I'm not going to go into because we just had lunch. But they include GI effects, they include risks of renal failure, and other life-threatening systemic problems. In order to achieve this wonderful gold standard of an undetectable viral load, you need at least 90% treatment compliance. And we've done work, we, meaning colleagues of mine and others, I haven't been doing this work specifically in this area, around the globe on how do we provide people with the, like Glenn Wagner's work on using time reminder pill cap lids to remind people to take their medication. How do we provide it in such a way that people get their medication? So in many ways, the problem is making the medication available, not just getting compliance with something that is, on the whole, a lot simpler than it used to be. Now, as we talk about what's happening in terms of health and health behavior, I've been writing for a long time. This work was about 10 years in the coming, with my co-author Pat Ricker, about a theory of constrained choice. So we do a lot of health research, one of these, here we go, on this lower part of the model, on how people's individual choices and actions contribute to their health outcomes, morbidity and mortality. And most of that operates through biological processes, allostatic load, stress response, and so on, we talk about here. Now, I do a lot of work on this part with Teresa Seaman, who would argue everything that happens to you goes through biological processes, including if you got hit by a bus because something biological happens and therefore you die. So it all depends on how you look at this problem, whether you think that you need this extra arrow. But what I bring as a sociologist to this is that down here is the individual, this nice little green area. Individuals have agency. They can make choices, and we can motivate them to make choices that are good for their health, that are good for population health. But they're not the only ones who have agency in their lives. Many of the decisions that are important to your being able to pursue a healthy life get made at levels above the individual. So we can think of an individual as nested in different kinds of communities and contexts. But what's important here, or what's important for me, is that in those contexts, there are other decision makers. So if our intention is to support and create people living a healthy life, we can go farther in doing that. Not only by understanding the disadvantages they may face and how we would help them overcome them individually, but by thinking about what can we do with employers, workplaces, work settings, or families, in order to have decisions made that would support them in being able to have a healthy life. And that can mean having stairs you can go up and down safely and in the workplace, having good nutrition available. Another obvious piece with employers is the kind of health insurance that you have. Do we do things that make it very, very easy and inexpensive for you to do the things we know are most effective in maximizing your health? Because health plans haven't always been designed that way. Also, at the community level, communities do things that make it easier or harder to pursue a healthy life. They can make it easy for you to engage in active commuting. They can put in bike lanes. They can put in kinds of public spaces that are helpful to people. They can do things to help improve the air quality. And we have a wide range of public health research. One of the most recent pieces that caught my eye this week is on the county level bans on trans fats, reducing the incidence of cardiovascular mortality. One of the problems we have with the community and the social policy interventions is a lot of what we've ever done that works falls in the paternalistic, or it's sometimes called nanny state aspect of we ban something. And banning something or controlling the supply of it in certain ways can be very helpful if we're trying to stop someone from addiction, from engaging in something that we think is particularly dangerous. If we want to try to make an environment safer, we want to add seatbelts to cars or lower the speeding limit, other kinds of things like that. The things that we do that would encourage health behavior or make it easier to lead a healthy life often get put in the category of welfare state. Sometimes also called nanny state, but usually not what's meant by it. But we have a range of things all the way up to social policies, which might be state or local, and they might be national, that end up shaping your ability to pursue a healthy life. And the extent to which they do that, the extent to which it's important that we engage those and we think about how do we use those decisions, how do we make those decision makers be motivated to support positive health behavior. That becomes really critical as we look at the people who have the least agency, as we look at the people who have the greatest barriers, because in a context in which you have tremendous barriers to pursuing a healthy life, healthy choices become a luxury. One of the studies that just came out showed that where the zip code you're born in is a bigger predictor of how long you'll live than your own genetics. Now, anybody with an eGenetics background here is going to quickly say, and it's because they interact. They do, and it interacts at a population level. But one of the things I'm most concerned about is, to my thinking, and this isn't an NIH thing, none of this I'm presenting today is an NIH thing. I should have given that caveat at the beginning. It also isn't a RAND thing. It's a sociology thing. I don't believe that who you're born and where you're born ought to be the biggest predictors of how long you're going to live and how you're likely to die. And then not only is that true globally, that those are the best predictors, but that's true in this country. And that's an odd and unfortunate thing. And I think it's an addressable thing. And that's why I'm giving you a call to action today. So, I don't know what we have here. So I want to talk about a scenario of what happens when you get diagnosed, when a woman gets diagnosed with HIV. So we're going to start with Janet. Janet's a high SES woman, meaning maybe upper middle class. She's got stable full-time employment. She could even have insurance through her own job. You may not be aware, women are less likely to have private insurance than men. They're more likely, if they do in fact have private insurance, to have it through their spouse's job. Women don't, it's one of the aspects of a gender stratified labor force. They're more likely to have Medicaid. Medicaid traditionally didn't really cover men very often. It covered women, especially if you were already pregnant, and for 6 or 8 weeks after pregnancy, and then you're likely to get cut off. Otherwise, you're on Medicaid because you have complicated illness. So Janet has private insurance and has had a lifelong history of regular medical care. She's got a very good life going in many ways. She owns her own home. By contrast, we have May. May is lower SES and has part-time employment. That's not the kind of thing that provides insurance in most settings. So she's on public insurance. And she's occasionally received medical care prior to getting HIV. And May is marginally housed. She stays with a friend. Now, both Janet and May acquired HIV through heterosexual transmission. That doesn't necessarily mean they knew they were at risk, especially early in the epidemic. The women who, especially high SES women, who came down with HIV and then AIDS, they tended to be diagnosed before their husbands. They tended to be married. They tended to not have known they were not in a monogamous relationship. And they got diagnosed earlier because of the kinds of complications that women had, raging gynecological problems. And they tended to die first. And that was in the high SES world. My father-in-law is an infectious disease physician, now retired, who did his whole career in Kaiser Healthcare. And so that's the world that he was treating and seeing patients. May, it's a lot more likely, was aware going into it that there's risk, in part because how much risk you face in terms of your risk of contracting HIV has more to do with the risk in the population that you're a part of than your health behaviors, because people not only are similar in terms of their risk, their behaviors in terms of safe sex, reducing your risk of contracting an STI. The sexual risk behaviors are actually far better in May's community. And in general in the African American community and communities of color, in almost all of the communities where you have higher risk of infection, we see better prevention. So I wanted to get that off the table. So what does constrained choice suggest? will be likely outcomes for Janet and May? Well, first, what else do we know about them? One of the things we know is it's far more likely among women who contract HIV that they have mental comorbidities than the rest of the population, and that's much more likely to be true for May than for Janet. They're also more likely to experience violence. About a third of the women who are newly diagnosed with HIV have PTSD. They have had some recent experiences that are challenging, such that they have some other comorbidities going on. But in addition, half report recent or current violence in the relationship that they're in. And that's also disproportionately going to be May. So despite the fact that we want to motivate them to have positive health behaviors, despite the fact they both value their health, they know how to prevent transmission in general, and they largely get the same advice on it. The one exception being we don't understand, we do know that there is some risk of transmitting HIV in breast milk, and it's most likely to happen if you have mastitis. So the prevailing information today, if you're a high SES woman, is don't breastfeed. If you're a very low SES woman, it's go ahead and breastfeed. It's probably better than not. And the assumption is you can't afford to buy formula and supplements, so probably maybe you won't end up with mastitis, so it won't end up transmitting HIV. But that's one of the times where we've got these different paths of advice that go on. But those kinds of inconsistent advice are real problems for people. In general, Janet and May get exposed to different systems of healthcare. They get exposed to different kinds of advice. And so you can think of them as nested in different worlds where they're getting different feedback on prevention, and what's possible in their lives. So I mentioned the difference in HIV risk. It's important to think of people as nested in sexual networks. You can think of people in social networks. You can think of people as nested in sexual networks. And the risk of HIV, of acquiring HIV, has more to do with this risk in terms of how much STI is in the pool that you are connected to. And in our society, as much or more as any kind of racial segregation, we have very much socioeconomic segregation in who people end up partnering with. So the May is more likely exposed. She's more likely to be in geographic areas with others in HIV. She's also much likely to have what is sociologically we talk about as very low social distance. She's in social proximity. There are many more people in her network she's likely to get exposed to. And the lack of access to primary care, the lack of history of primary care, means she's more likely to have been somewhat immune compromised, to be somewhat stressed and challenged. So when she gets exposed, she may be much more likely to contract an STI. Now, we want to turn to thinking about the medical goals. Before we got to antiretroviral therapy, this was easy. It was doing whatever we could for a patient. So somebody had to get into the system, get diagnosed, and we want them to comply with care so they get the best outcome that they can give. Now it's changed a little bit because we have the possibility that we can help individuals or encourage individuals. I don't think we've gotten to the point of coercing, but we can help individuals to achieve this very low viral load. And if you are a high SES individual, and it's particularly important to you, the icing on the cake out of all of that, the big reward is that we believe that it is probably safe for you to have condomless sex. Based on the partner study, which has followed thousands of couples over many years. We're looking at, here in the partner study, it's looking at serodiscordant couples and the risk of transmission. And out of the last study I saw, the last publication I saw on it, out of 58,000 sex acts people have reported across the study, they haven't had any cases of transmission. Now that could mean you could be serodiscordant because neither of you has HIV, or you may have different kinds of strains they can document. But this gets relayed to patients as this is probably almost perfect. This is probably a fantastic thing. And my confidence in that is higher for higher SES individuals or individuals who don't already have another STI on board. But that benefit, that reward, is a luxury if that's not what's important to you. It's a luxury if what you need to maximize is balancing paying for food and paying for rent, or being able to continue to move through other family members and other places you can live because you're marginally housed, because you're already in a economically compromised situation. And you're likely to stay in that kind of economically compromised situation. You're unlikely to be able to improve your circumstances greatly after a diagnosis, in part because both the disease and side effects of some of the medications include cognitive complications, greater severity and length of time if you develop a cold, the flu, other kinds of routine things that we're all going to deal with in going about life. So we've gone from this medical goal, which is maximize your outcome as a patient, to this potential medical goal of maximizing the ability to reduce HIV transmission in a population. Now, when we go from the goal being all about you to about you and what happens to everybody else in the room, then we have an issue of who benefits. This is where we always go as sociologists. Who benefits from what's going on? And on the flip side, who should bear the costs? How should we deal with the fact that we're now not just talking about maximizing your health and providing care and motivating you to do a thing that's good for you, but that there are costs and consequences that go beyond. You're still dealing with the consequences and the challenges of your life and all of the reasons why you want to be compliant, and with the side effects of the disease and of the medication, but there are benefits to others. Now, this is very similar to other kinds of healthcare interventions where there are benefits to others. One of the ones I've written on is on reliable contraception. Reliable contraception is not only of benefit to individual women, it has benefited our economy tremendously. It's benefited the return on the GDP. It's of use to employers. It is very helpful if you are able to have only the number of children you wanted to have and or have them when you want to have them. Doing that, if you only want to have 2 children, means at least 3 decades of access to reliable contraception. So one of the ways to look at the returns to the contraception is to say, maybe somebody else ought to pay part of the cost. Maybe there are ways that we could motivate going with this long-acting reversible contraception that came up in the last talk, is sharing the cost, is getting rid of a copay, is facilitating and making it very easy for the individual to make a choice that's consistent with what we now as a society are interested in. Now, that being the case, where do we aim the behavioral interventions? Now, one possibility is we're going dead on to the center, and you can think of that as on target with the individual patient, the individual potential patient. But another possibility is you say, well, that's a really great place to put part of our effort. But maybe we also want to be thinking about how we can intervene, how we can be supportive of other levels of decision making, encouraging or facilitating your being able to be compliant with medication. Maybe we can look at, it's not just the very narrow aspect of behavioral economics that we've talked about so far this morning that motivates your decision, but the broader issue of what are the costs and where would it make sense to invest as a society or as an employer in making it easier for someone to have treatment compliance to achieve that. Now, what do we actually do as a scientific and research community? We don't do a lot of that. We tend to do 2 kinds of research when you look at the literature. We do the population health, where we're looking at, I've got too many pointers here. We're looking at the group, and I can tell you about the incidence of HIV in the population. I can tell you about racial disparities or socioeconomic gaps in care, differences in what's happening to men and women. Those are the writ large public health story or medical story of what a problem looks like. They don't necessarily, other than the work that's looking at how the variations are happening across populations, they don't necessarily get us to how do we intervene in particular ways. Then the biggest part of the research that goes on is down on the left, on the individual. So we do a lot of studies that look at how individuals are nested in communities, they're nested in groups or clinics, we've intervened in particular ways, and what's the return on that kind of investment to the individual? What's the return on a particular form of treatment? What's the return on a particular kind of incentive that we put in place on average for the individual? Is that enough? Is that the way that we can shift those other levels of decision making? Now, I would argue that part of what we're missing is that transdisciplinary research, but another part is we aren't writing about, thinking about, or talking to these other stakeholders, these other decision makers about what's working and what's not working, about what, that they in fact already have skin in the game because they're bearing costs. And I find in research that is often a very helpful place to start with people, to start with explaining this is costing you time, resources, clinic time, whatever is on the table. So it's not just that I'm going to someone and saying, I think you ought to add this to the way that you're treating or intervening in a kind of care, but that a problem that exists, like health literacy, already means patients don't show up at the right time at the right place. It already means that you have patients who can't show up prepared for specific tests. Therefore, you have a vested interest in figuring out how we can use knowledge about health literacy or predictive health literacy in order to intervene. In this case, we already know about the consequences of transmission. We already know about the costs of additional cases. How can we use that information and put a value on prevention of transmission, put a value on the kinds of achievable outcome, and write to those audiences? We may be aware that they're audiences we would like to think of and use our research, but we don't usually go the step. We mainly, where our obligation, having gotten funding, ends is somewhere fairly soon after the journal article. And that's a really good marker of productivity in research, but it's not a very good marker of impact. It's not a very good marker of whether we did the knowledge translation that got our work out there in such a way that it gets used, that it is available and can make the difference with the populations we want and need to be impacting. So there's a big communications piece that's possible here. I should also note that in other countries, this is taken a lot more seriously. Canada has a very high priority in their funded research on knowledge translation components and where is the work getting disseminated. One of the problems of having it end with a journal article is you kind of need to be able to read odds ratios and be excited about them. And in my experience, if you don't produce odds ratios for a living, they don't make your heart go pity-pat. And what's a big odds ratio? Well, if you study individuals, it's 2 or 3 or 5 or 15. And what's a ridiculous one? And it means you did the study wrong. Well, that depends on what you were studying. It depends on what's normative within your little subdiscipline. So it's not like there's something I can just give the congressperson or the person in charge of all of healthcare costs for Verizon a little algorithm so they know how to read this information. The other issue is when we're interested in health beyond the individual, a large odds ratio may be 1.06. 1.06 is the difference in income by race on average in this country. It's not massive. At a population level, that's enough. That difference in the two distributions is enough to cause a tremendous amount of pain and complications and problems. It's enough to make a very big difference. But we need to be able to come up with a way that we can talk about our work reliably, conscientiously, and not just in the way that we talk to other scientists about it. I'm not going to get half an hour with a governor or a congressperson or the key member of their staff to talk about all the caveats and limitations on my research. I have an opportunity to go in and say, this is relevant, this is why, this is what you could do that would be useful with it. So from that perspective as well, this is why you need to do the transdisciplinary training, and this is why you need to think beyond the journal article publication in terms of how do I get this information to who could be using it. And how can I figure out ahead of time when I'm planning a study, who would this be useful to? Who would use it and have it have an impact? And talk to them about what would make sense to them. So this is like community-based participatory research, but the community isn't just the community in a low-income neighborhood of some particular characteristic, or some racial ethnic group, or some religious group. It's the other stakeholders at these other levels of decision making, and talking to them about what would they want to know, what are they concerned about, and explaining how this fits in with what their concerns are. So let's go back to Janet and May. What are their barriers to consistently taking their medication? Well, they're living and operating in different worlds. In Janet's world, she's got private health insurance that probably works pretty well for getting her the medications that are consistent with the outcomes. In May's world, there are more barriers just to getting appointments. There are more barriers to getting seen when you have a problem. It's more likely to be a problem when you show up in ER. There's less likely to be urgent care hours that it's easy to be seen, and so on. They face different kinds of hurdles. Now, this is important because our models for motivating behavioral change may be really good for Janet, because Janet has fewer barriers, and she has the opportunity to have a middle-class life out of this, potentially with a life expectancy that is a lot more like what she had before. People understand a lot of things about their lives. And so one of the things you're working against here is that Janet's actions are consistent with being a person who's had a middle-class life, who has skills about negotiating health care, barriers to care, getting what she needs. She likely has a high level of health literacy, and if she doesn't, she's in a network that does. It's not that hard to get the information and get to what she needs. May is in a world that is very informed as well. May's world knows a lot more about how do you get on unemployment and how do you deal with it. How do you balance paying for food and paying for medication and trying to keep a roof over your head? May's world has a lot more information about how do you step up and take care of somebody else even though you're already ill. She's living in a world that has a lot more problems that come up that would stop the rest of us. And the solutions she has and the knowledge in her world of health literacy is much more likely to be dated. She is more likely to get poorer information or information from less informed people. Not that she's acting consciously saying, I'm rejecting a Western medical model and choosing something else, but that the information she's getting is more likely to come from others who don't have the same kind of access to medical advice, to expertise. She's not likely to live in a world where the medical professionals who are in her social network are physicians and highly trained RNs. They're more likely to be LPNs, orderlies, or people who know a little bit about how to manage certain aspects of care. So there are a lot of barriers that are in place, and they're both going to act with the knowledge they have from those worlds as they make their own efforts to achieve an outcome. They're going to act, and you know this from your first class, you're going to act based on your understanding as an individual of the probability of success. And if Janet knows the probability of success is pretty good, that there's always somebody she can bump it upstairs to, that she can keep pushing on this, she's going to push a lot harder when problems happen in getting her medications and getting care. And that's where I want to get to next, is what happens when there are problems in getting care. These are 3 cases from Martha's work. Martha has been working in HIV health and healthcare for I think a couple of decades now. It wasn't what she was working on when I first met her, but she's been in this arena for a long time. And so she looked at what are some real stories of people transitioning in their healthcare. This is one of the times that you run into two problems. One is a woman transitioning from one kind of private insurance to another in 2006. And she started the process in your logical way, going to the old practice, transferring her medical records, lining everything up well ahead of the move, signing COBRA, in this case being COBRA Health Insurance, not COBRA Behavioral Interventions, but doing the paperwork. It costs a lot more to buy your health insurance when you pay for it through COBRA, but she could afford to do that. So she pays the monthly premiums, transfers her prescriptions. They're at a brick and mortar pharmacy. She goes there. She moves to the new insurance, meets with her new provider, and it's all taken care of with relatively easy paperwork 3 months later. And that's what can happen in her world, in a world like Janet's. In case two, it's a more recent case. This is an individual going from public insurance in one state to public insurance in another state. Both of them had the Medicaid expansion. That's very important to understand. We don't have a national Medicaid system. We have state systems. This is moving between two states where it's pretty good for HIV care. So she starts the same process, notifying practices, calls Medicaid, sets everything up, gets told how long it's going to take. In this particular state she was moving to, this woman needed to register to vote, and that was the process for establishing residency. There are different rules in every single state. Nobody's going to be an expert on all of these possible transitions. And she goes to the intake appointment and is told she has not been removed from the rolls in the other state. You can't be on Medicaid in two states. She can't be seen. She can't initiate this process. She just has to leave that appointment. She's not eligible yet. She goes through a long process on phone inquiries, finds out where it was never processed, and goes through, including traveling back and forth between the states in person to get this set up, finally finds the person who acts on her behalf, and is able to cancel the old one, get coverage under the Ryan White in the new state, and eventually, it's only 48 hours to get it done. This woman was educated. This woman had confidence that this could get done. But along the way, there were at least 6 opportunities that Martha noted here, where the patient could have been lost to care. There could have been a gap in coverage. You're supposed to be having 90% compliance with your medication to keep below a viral load, below a detectable viral load. And all of these things could kick you off. None of the states are saying, here, let us give you an extra $4,000 month of medication to tide you over while you get across the transition. There are many systems